will try to make a presentation and a provocation. I will provoke you. I want to launch a set of ideas that probably will cause an important debate. And in that thinking and reflection that I want to promote, the central idea is how policies are prepared, who has influence on the preparation of policies, how are decisions made in the area of health. Why is it decided to change the criteria for diagnosis of a pandemic? Or why is it decided to introduce or not introducing a vaccine within this vaccination scheme? On how priorities are defined in a ministry, or which are the criteria used to determine if a medicine new is going to be used. All these are political decisions. And in all those decisions, there is a set of interests that collide. And this is the central topic, the contextualization of public policies in health, and see how are today in the present world the determinants of those health policies. And I have prepared my intervention in 2 blocks. I have 1 hour, so I will try to do it, to have 25 minutes to some ideas on the social determination of health, trying to understand the difference between social determination and social determinants, and bring some contributions from Latin America in the discussion of social determination. I am going to use an example of policy, the Commission of Social Determinants of Health of WHO, and we will be referred from the perspective of a thing which is essentially the counter-hegemonic thinking, because the hegemonic thinking in health is disease. Ecuadorian Dr. Falcone, Edmundo Granda, he said that in Latin America we never had ministries of health, but ministries of disease. He said that we were not specialists in public health, but in public disease, because the domineering part in the thinking of health is disease. If you want to build policies for health and not for disease, we have to formulate this perspective from the concept of hegemony and counter-hegemony. I am referred to a counter-hegemonic thinking in health. And in the second part of my presentation, we will be seeing the topic of public policies and how they are determined. For example, the central policy in the 90s, which were the health reforms. Who determined the reforms? How were they determined? And I'm going to use the central topic of the comprehension of the medical and industrial complex in health, and especially of the pharmaceutical industry as a determinant of the public health publics. And we will also be mentioning about what we can do in view of that situation. This is the scheme that I'm proposing from my presentation. Let's begin. Social determination of health. Certainly, I have the 3 schemes of the academic evolution here of social determination of health. The London, Canadian attorney, and then we have the Dangos White Hair during the 90s, and then the Commission of Determination, Social Determination of Health of WHO. which is the social determination of health. This is a category that we have taken from political science and social sciences, and it is mainly the category that allows us to explain and understand that health is essentially a social fact, allowing us to understand that. Where is Alfredo? Where is Alfredo? Alfredo, please. That allows us to understand that health is a interdisciplinary fact that goes beyond the biological side and which is essentially a social fact. This category of social determination of health and disease is is taken from the social sciences and explains that the fundamental causes of bad health are in society and not in biology, not in nature. They are in the social structure, and this the Commission of Social Determinants says that the main problem of bad health is the inadequate distribution, improper distribution of richness, power, and services in society. Therefore, this is a debate, this is a very old debate. This is a debate that has gone through history, but I will take an example of a debate in 1882 in Berlin Medicine Academy. The debate was between Virchow and Koch. In 1882, these two men of science, of health science, Rudolf Virchow, the father of the cellular theory, said that the main causes of bad health are in society and that we have to fight to change them. Society must be changed. He was not only a scientist but also a social fighter. He was a representative. He participated in all the revolutionary processes in 1840-50 in Europe. Koch was a scientist that proposed the diseases caused by germs. Just one cause, unicausalism. In 1882, because Koch, being the president of the academician of the Berlin Academy, he said that TB was caused by a bacillus, which is the Koch bacillus, which described it for the first time ever. And therefore, he has the thesis on unicausalism. And this is a long discussion for decades. And Virchow said, no, the cause of TB is not the Koch bacillus. Virchow said that the bacillus is the necessary cause, but not the sufficient cause or the enough cause for TB. And he said that the main cause of TB were the conditions in which the people lived, the way their nutrition or malnutrition. That debate that started in 1882 is a debate that goes through history of medicine and the history of health. The debate among two conceptions, two views which collide about medicine and health. But who won? Who was the winner? The debate. Who received the Nobel Prize? Koch received it, and not Virchow. That means to say, throughout history, the conception that predominated is that of unicausalism or a multi-causalism reduced to small factors. Okay? Virchow was considered the father of social medicine because he was the one to use that term, and the first one to say that the political and social structure is the origin of disease, and the only manner of having good health in society was change the social structure that gave rise to disease, and that policy, therefore, is a fundamental tool for virtue said. Medicine is a science, a social science. But what happened with that debate throughout history and throughout the years? When in Latin America, social medicine and collective health are proposing this for a long time now. However, a biologistic thought has prevailed, which is centered on disease. My colleague from the Argentine, who is this man here? This is Ramon Carrillo, the first Minister of Health of the Argentine. Ramon Carrillo said this, which is extraordinary. In view of the diseases generated by misery, in view of sadness, anguish, and the lack of fortune of the people, the microbes as a cause of disease are poor causes. Carrillo said that during 6 years he was the Minister of Health, and he is considered the father of social medicine in the Argentine. He was a minister at the beginning of the 50s, and he was exiled during the first dictatorship in Brazil, in Belém do Pará. He died in 56 here in Brazil. That means to say that the Argentinian government pays honors to Dr. Carrillo with a stamp that you see. But this is so the question is, why having people as Carrillo? Who is this one? Salvador Allende from Chile. But Salvador Allende, not as a president. He is Salvador Allende as a Minister of Health in 1930, when he was 31 years of age. Salvador Allende, I went too quickly, he says. Salvador Allende, he wrote a book which is called The Medical and Social Chilean Reality in the 30s, and he said, a man in society is not an abstract thing. He develops, lives, works, and he gets sick and dies according to the environment in which that is the social condition of disease. And in the year, and then he became the president, and he was the one to create the first health system in the continent, the Chilean system, which then was destroyed during the Pinochet dictatorship. So these are very important contributions of Latin America in the area of social medicine. Who is this? This is Jaime Braille, which in the 70s wrote this book, it's called Epidemiology, Medicine, Politics, and Society, on the basis of social determination of health. I have handed to Juan an article, I have it also in my pen drive, on the social determinant of health, the difference with determinants, and the concept of social determination as a key concept for transforming the daily life of public health.
And also in Brazil, who is this one? This is Carlos Chagas, a famous doctor. Epidemiologist Carlos Chagas said, actually early last century, that when he described the disease that now is called after him, which is the disease of Chagas, he was one of the Science of Fiocruz, which is Fiocruz Foundation. He started with the Pasteur Institute of Paris, which is a research institute, was also very important. The Osvaldo Cruz Foundation was made. Gacho Chagas actually were not the chinchucas or the vectors of these bugs, but also poverty and the bad governments that have our peoples living in misery. Chagas said it in 1910. And still today, we have more than 10 million people that suffer from this disease in the whole continent. Who is this gentleman? From Colombia, Hector Abad Gomez. Today, the Public Health School of the University of Antioquia holds his name. There is a book written on him too, from a very famous person who is Hector Abad Fashionix. So the book is called El Olvido que Seremos. Also, people are going to study to the Public Health School. I don't know who he is. Well, last time we passed through a street that has a name, and people don't know who this person was. So we forget. These people are forsaken. These are forgotten. And as most of the Argentinians perhaps don't know who is Ramon Carrillo, and who is this one? This gentleman here, this is Hilberto Rodriguez Ochoa. He wrote a book which is called La Alienación de la Medicina, the alienation of medicine. Who was Minister of Health in Venezuela also, he said the worst disease is life that we'll have, the life that we'll live. So these are part of the Latin American production on social determinants in health. As you just mentioned, in Brazil, Sergio Arouca, who wrote many years back The Preventivist Dilemma, and allowed us to generate this movement within the Brazilian public health reform. Cristina Laurel from Mexico. Here we have another important Brazilian, Naumar Almeida, Juan Cesar Garcia, precursor and founding father of this thought, Edmundo Granda, Juan Samaja. I would like to say that this is a deeply rooted thought, but then the key question would be is what happens with social determination in health? Why, despite this intense production, social determination in health is hiding, is occult, is concealed, is reduced in practice to social determinant factors. We stop talking about determination when we start talking about determining factors. The determinant factors are reduced and we are turned into the traditional old-fashioned risk factors. So this is the question that we'll try to respond to today. What happens with a category which is key in medicine and health, but is occult or hidden away, or that is just reduced, also that is reduced into reality? Why cannot we incorporate this into policies, and why is it the policies are just focused on primary care? Well, the vision of Koch, yes, it became a dogma, she says. Koch's vision became a dogma, she comments. This is what we are going to be discussing, how the vision, the multi-cause vision has been the hegemonic vision. This, we are going to see a few examples. The first example that I bring to you is the history of the Commission of Social Determinants of WHO as an example of a policy that was designed, of a policy that has tried to be forgotten and also set apart. The Commission of Social Determinants was created in 2005 by Dr. Leek, who was General Director of the WHO at the time. He was a commission made up by 20 people with several former presidents or presidents of different countries. From Latin America, we had Ricardo Lagos, also former president. Or from Chile, where many Chileans have participated. Janet Vega was also there with Ariel Solar. They were very important people. They were personalities that for 3 years this committee was intensely made a collection of the knowledge of public health inequalities. Is something that is going to be approach tomorrow in social determining factors in health. And since from 2005 to 2008, they worked and presented a very interesting report. They constructed this matrix. This is the matrix. This is a conceptual framework of social determinant in health. Even the committee of WHO also that talked about structural determinant factors that raise the social, economic, and political contexts that besides also raise important determinants that we generally forget. For example, the social class factor. Also, in another factor, also they have to do only with domestic violence, which is the gender determinant factors and the traditional determinant factors too. So this conceptual framework allowed us to get to a few important conclusions. This is taken verbatim from the report that was introduced by the committee. This commission said the social injustice is killing the population. This is verbatim. The relationship of inequalities in health, no, I'm sorry, the reduction of inequalities in health in the countries is actually an ethical imperative. The distribution, the unequal, uneven distribution of experience that actually are detrimental to health is not a natural element. Gentlemen epidemiologists, there is no natural history of the disease. There is a social history. So for us to understand that this history comes from the combination of social policies and deficient interventions of unfair economic situations and bad policies. This is what the report contained, made up by the committee in 2008. And it said these also are copied verbatim from the conclusions. The three recommendations were given in the report said the only way of improving health is by improving the living conditions. It's changing the circumstances in which the people are born, live, age, and die. And these can only be done fighting against unfair distribution of power, money, and resources that are the structural factors that determine the living conditions. And also, he said that this, once does it, we have to measure the problem, we have to assess the impact of policies. And he concluded the report saying that equal distribution of health and disease is a problem, basically, of social justice. What happened with this report? Well, actually, it was criticized from the conservatives. I bring you only 3 examples, but I have tens. From The Economist said that the report introduced by the Commission on Health has been politicized. They tried to change the paradigm that have dominated health. Yes, this is it. From Lancet, also this author brings that there is an important bias in the report by the Commission. From a Fraser Institute that works also for the market, with the market as an important axle for the community, it said the report was diseased. So there were an avalanche of hard criticisms against the report. And what happened? Well, the report was filed away. The WHO today doesn't assume its conclusion, says no. Clearly, I was talking to a representative who said these are non-conclusions of the WHO, so they're conclusions of the Commission only of social determinant factors. Also, he endorsed these because WHO was not able to absorb them because of these, in the way that were just designed as out of this moment on. We had a process of trivialization of the concept of social determinant factors in health. This also, we had everybody talks about social determinant factors in health, but it has lost its political strength. The determining word doesn't mean the same to me. or to any other or any other civil servants, other ministries that reduces them it just to risk factors. Brazil tried to bring back this topic and proposed and financed because 3 years actually was just sleeping in the offices. We say actually in the offices or in the drawers. Brazil understood this reality but tried to rescue it. It proposed and financed the Global Conference on Social Determinant Factors in 2011. We had the participation of 120 countries, and so Isags had a very important participation in this important conference, and also the issue was included in the agenda, and also some fundamental aspects were brought to light. We're talking about integrality that implies in replacing the biomedic model, and so we need to have a model focused on health. Intersectorality was highlighted. Also, the public policies have to be designed within interdisciplinarity, intersectoriality that we mentioned in the morning, in which the issues were not just health or disease, but also education, nutrition, housing, work, jobs, etc., and in which we brought the key element, which is a social participation in community work, with the social organizations as a key element within the construction of intersectorial health policies. And as we raised the issue that was widely discussed, but not in the report, which is the global crisis of capitalism, the civilization crisis, and the need of having a new model for development and consumption as key elements to be able to face the different problems of diseases related to diseases. So this report actually once again stays actually is kept away, occult, hidden from reality. To understand basically the center of what happens around social determination in health, we have to do it from the counter-hegemonic perspective, counter-hegemonic focus. What is hegemony? Hegemony also is a concept of political and social science. It comes from this Italian who is called Antonio Gramsci that tells us that every society has a dominating class, and that this dominating class from the subordinated classes at the rest of the society from them to adopt without physical coordination, physical coercion, the ideologies, which is hegemony of the dominating class. The dominating class, Gramsci says, educates the dominated or the rest of the society so that they can live actually being submitted as something natural, and this is done through the educational system, through religions, through legislation, through today basically through the mass media. Also, people are domesticated. So this society will think uniformly. Also, this is said in other words by Ramonet, who was director of the Le Monde Diplomatique for many years. He used to say textually, actually, we dominate much better. Either one is dominated is unconscious. The relation of domination is not based in strength. Actually, after the conquest, now we have to control actually the spirits. In other words, and not to put it in graphic terms, this is a time of colonialism when we were dominated by physical coercion, but this is a time of colonialism where we dominated also with the ideas that are imposed on us through domestication and hegemony. Also, we live in what is called today the times of hegemony, planetary hegemony of capital and market. And how all this is translated into health terms. The first time that hegemony in health is mentioned was by this social scientist from Argentina, half Argentina, half Mexican, who is called Eduardo Menendez. He constructs the world actually of a hegemonic medical model. He says the hegemonic medical model has three basic characteristics based on the disease. So hegemony in health We are not talking about health, but we need to have the disease. This individualism is actually has no references in politics and space and time, and it's individualistic. And also, besides all of this is why very important, as Alfredo said before, this hegemonic medical model is legitimized within the juridical and academic society through a knowledge that is scientific, quote unquote, and that dequalifies other types of practices and thoughts, that dequalifies interculturality, traditional knowledge and customs of our peoples, that says that we are ideological, the ones who speak like I do now. So there's a delegitimation process of this thought and of delegitimation of this type of thought as of what is being developed by them. So what we find ourselves into the situation that definitely there is a shock in paradigms. Historically, also the different models have clashed of explaining health and disease. In most of the greatest contradiction happens between this model, who is the one of Koch, but transformed multi-cause empirism is focused on risk factors, and social medicine in Brazil, which is called collective health, which is basically focused on social determination in health and critical epidemiology. I use a word here from Bourdieu. He says that science, as any other symbolic operation, is a subordinated, transfigurated, trade or recognizable transformation of the relationships of power in the society. We have a science. This delegitimizes this idea. This is the end of the first part of my presentation. The focus of social determination is a focus in which there is a confrontation, there are different clashes, but for us, what matters is to see that health in disease in our society depends on the organization of life and the production and distribution of social wealth, and how, therefore, the policies, intersectoral policies cannot be just related to health. We need to have public intersectoral policies also should act on this ensemble of elements. Social determination of health goes beyond the analysis of risk factors and lifestyles, because otherwise we are going to be leaving the promotion of health is acting on individual lifestyles. We have to act basically on the big social determinants of health, and this requires analysis of the social context that produces life, and therefore where there is health and disease. This is a conclusion of my first part of my presentations. As Alfredo would say, this is an invitation actually to be able to think out of the box. It's an invitation to interdisciplinarity, intersectoriality, to understand that health requires our actions within the social context. And this, I recall Inting now, who told us that you want to have different results, also stop doing always the same. We want to have different results in health. You want to have intersectoriality. We want to act on the determinant factors. We have to do something different vis-a-vis what we have been doing before. And now let's go to the second part of my presentation. And we are going to be seeing, we introduce the concept of social determination. We differentiate it from determinant factors when we talk about the public policies. What determines policies today? Firstly, public policies might be decisions, might be actions, might be standards or norms, can be legislation, but they're established by the state to resolve problems, or those problems that do affect the community or the collective, and public policies are expressed into legislation when we have a health legislation. This is public policy expressed in decrees. They're expressed in different resolutions and regulation, in documents, in norms and standards. All of these are public policies or ordinances. We are seeing what actually determines what are the big determinant factors of these public policies, understanding that then public policies are the ones that are geared towards those needs, the unmet needs or non-acceptable situations, to modify, to generate situations in order to improve, to ensure rights. These are all the public policies. Let's see now this public policy formulation process that requires in this fundamental actually a conjunction between knowing and between formulating policies and make decisions. This whole process is a process that requires a deep diagnosis, as Alfredo said, that actually of doing a diagnosis that has to be done intersectorially. It has to be done interdisciplinarily, with interdisciplinarity. Otherwise, we're going to have just one part of the reality. A diagnosis that necessarily has to start from identifying collectively and interdisciplinarity and sectorially a problem. Understand this problem allows me to formulate a policy, and develop this policy allows me to construct an agenda so that this public policy be developed. And then when we forget, we have to assess the whole impact produced by this policy. I'm going to put you an example. Very short policies. One of them you can see the relationship between policy and action and decision-making process in 1980. Let's imagine the countries of the world decided they committed, which is called 0.7% in the session of the General Assembly of the United Nations. The developed countries took up the commitment of a policy of assigning at least 0.7% of the GDP to aid for development. Let's see what happened with this policy at 2013 already.
Some years afterwards, only five countries have have fulfilled this mandate: Luxembourg, Switzerland, Norwegian, Denmark, and Holland. The Netherlands are 0.7 of their GNDP for the development. The other countries, no, have failed to do this. So this is important. It is not sufficient to have the policies, it's how the policies are implemented in practice. Public policies and health systems. The whole system, WHO defines as the set of actions, norms, organizations, and people with the intention, the main intention is to promote, recover, or improve health. That idea is the Isags. We see an improvement here. In the book you see at the entrance of the building is their network of institutional responses, programs, activities that build a society, built by a society to provide a response to the needs and demands of health of the population, to promote, protect, and recover health. Is far more complete. The Isags definition is far more complete than the WHO one. And in that text, I think it is important for you to take it. At least in CD, we have an analysis of the health systems in South America. The health system is integrated, made up of four great components: the policies and norms defining the organization and functioning of the system, the professional technicians and people, the network of services and the models, and the necessary products to comply with the objectives. And the health system, as the text says, is determined by the idea of health that prevails in a certain society, and by the health policies that derive from that. So we will see now the topic of the policies and of the system. I'm going to make a brief summary of the evolution of the health systems in Latin America. At the beginning of the 20th century, there was no Ministry of Health. There was no Ministry of Health, no WHO. So in this 20th century, we have no, at the beginning of the 20th century, we had no health systems in Latin America. The PAHO is created in 1902. The Rockefeller Foundation is created in 1913. The Rockefeller Foundation is the philanthropic arm of the great company, oil company, Exxon, that creates the Rockefeller Foundation as a mechanism to help American countries to eradicate the epidemics that prevent oil exploitations, according to the experiences of the 19th century in the Panama Channel, in which a French company tried to build the channel, and it was not because of the yellow fever attacking all the workers, so they had to call Finley to fight yellow fever and eradicate yellow fever, and they then built the Panama Channel. So this is a concern which was that was created out of commerce, because what we had was charity for the poor people before that. So we had the ministries of health. They started to appear by the hand of the Rockefeller Foundation, in Chile in 32, in Peru in 35. You have Alicia, the last one was Ecuador in 67. And all these ministries are organized within a deep contradiction between vertical program and integral programs. From the beginning of our ministry, there is a collision between the program of fight against malaria, which was very powerful, and the more integral idea on health systems. Then we have the World War, and when it finishes, we have the welfare state in Europe in the post-war era that gives rise to the welfare situation, which are the deep transformation processes after the Second World War. So we build the welfare state. There is a phrase of Bismarck, which is little known, but I think it's important. Bismarck, in 1896, in a letter addressed, or we build social security system, or our workers will organize a revolution. So his proposal is very clear. The building of social security systems in Europe are a barrier to the process of social transformation, which after the war appeared and developed. The Bismarck concept was then distorted and is taken to other countries, so we have the social insurance. This history, this is a very clear history in Venezuela and also in the other countries. In Venezuela, the Minister of Health in 1937, Aníbal Santos said he resigned because the Congress approved a law creating the Social Security, because he said it was a contradiction that will make a fragmentation of the health system. Yes, in fact, it was there was a fragmentation, because in our country we have ministries of health, social security institution, one for the poorest population, other for the workers, and then we have the corporate medicine for those who can pay. In countries like Argentina and Uruguay, the Association of Laborers have their own security systems and social security system, and the main characteristic of our system is that they're deeply fragmented, in which we have different structure public ministries of health, or whatever you call it, which are especially for the poor people. We have social security structures for the working people, and then we have a set of private insurance or prepaid insurance sectors, which are the prepaid plans of health plans, and also we have private medicine for those sectors that can afford it. Then in the 90s, we have the neoliberal reforms that dismantle the ministries of health, producing an intense process of privatizations. I will refer to this in a minute. And then we are now in 2000 and something. In some countries, we have counter-hegemonic governments. UNASUN is an expression of that strategic thinking. Temperano said it's a center of strategic thinking in health. And the strategic thinking in health has the involves the counter-hegemonic thinking for us who work in health. And we are then having the concept of health as a human and social fundamental right. And we are proposing universal systems in some countries too. But if we wish to understand the situation, we have to visit the dominant policies in the 90s, in the 2000, and also at present, which are the reform of the 90s. The 90 reform was proposed, taking into consideration the ideas of Milton Friedman, which is in his book, Capitalism and Freedom. The reform were beyond the health sector. It was the reform of the state. The structural programs that derive from the Washington Consensus, those policies, structural policies in many Latin American countries were used and known as the neoliberal policies. And these neoliberal were born in the Washington Consensus. Which was this, the Washington Consensus? It was a meeting of 20 health economy experts organized in Washington in 1989. Well, we have the experts of the World Bank, the IMF, and they developed the rapporteur. Then writes some interesting article which he explains that if he had known that they were going to apply that policy as in other countries, he would have never written what he wrote. So diminution of the public expenditure, participation of the private sector, privatization. You know what happened during the privatization era in electricity, health, deregulations, also, and guarantee or ensure the right to private property. That is to say, reducing the size of the state in order to reduce the domineering situation of the state, and this is what we call the neoliberal health proposal, which is clearly written in the text of the World Bank, which is that health is individual responsibility that pertains to the private sphere and should be resolved in the framework of the individual, his family. The state just provides minimum assistance to those who need to satisfy their bare necessities, the minimum necessities. That means to say, the thing was to create a health system based on the market. The main policy was written here in this book, which is called To Invest in Health. Focus attention to the poor, separation of functions, I am not getting the sound. I am reading just the slide. Separation of function, leaving the state only the direction, decentralization, diminishing the responsibility of the state, and recovering costs. That is by charging for the services. We are not. This Joseph Stiglitz, who was a president or vice president of the World Bank and one of the economic advisors. He received the Nobel Prize and wrote two excellent books. And these two books he wrote, Happy in 90 and The State of Globalization. He explains how this reform failed, weakening the state and diminishing social expenditure, and dismantling the health ministries, creating parallel offices in all the countries to manage the reforms, which were really they increase the debt of the countries. We have diseases already controlled reappearing, polarization or epidemiological accumulation. Our countries haven't had any transition. We have the old diseases and the new ones of the new industrialization. We haven't had a transition from one model to the other, but accumulation. Environmental loss of rights, increase of unemployment and of informal economy, concentration of richness, and increase of poverty. A report has been published, and today 1% of the richest in each country control more than 50% of the wealth of the region. That means to say there are 99% of the society has to live with 50%. So there is an enormous concentration of social wealth, and that concentration and the inequalities and the consequences of bad health and disease in the society. They cause the disease in the society. In this, the neoliberal policies are, however, disguised. There is a fight for the discourse. They use terms such as right to health, determinants, participation, interculturality, reducing them to words without content. So it is privatized in the name of the right to health. And also they say that they are speaking about focus programs, universal insurance, decision makers, without explaining how these evidences are. And what happened with international organizations? In general, in the last years, they are functional to the market of the capital. They take up proposals. They have been co-opted by the medical industrial complex, Gates, Rockefeller, and BM. That is why Gates inaugurated the WHO Assembly. An example of this situation is the ranking of the world healthcare systems, which was published by the WHO in this text, in which countries like Brazil, that had a health system, is below. We have Colombia and Peru, which are the only systems that apparently they were implemented as a market systems. So this shows how the international organizations co-opted the ideas of capital and market. It was a ranking of world health system for the market, but not for the people. This I took from the PAHO internet page, talking about insurance. It is defined as a guarantee of access to a set of assistance for the inhabitants or for special groups in the population through arrangements on the management of risk. At present, the new fashion is the universal health coverage in the General United Nations Assembly, the WHO, together with the Rockefeller Foundation, launched a report on the universal coverage of health in the 2013 Assembly with a commitment of universal coverage, and the BIT, IBD, and the World Bank offered their support. A group of experts was created in order to advise on the path to follow towards universal coverage. They are not experts from countries, they are experts from international organizations. And where it is not said here that in other meetings on these topics, I always remember I sent Juan a copy of this. This is a union which was promoted by the private sector working in health in Velayo, in the center of Rockefeller, and they came to the conclusion, the Davos 2013 Davos Forum, and the main report was the relevance of universal coverage as a proposal, taking into consideration the interests of capital and market. And this was taken to all the countries. This is a cube, which is like a Troy horse, only in which we have only the interests of capital and market, which is the main determinant of the policies. In the last decade, there have been a substantial change in life, a fundamental change of work and health, a change of era in which there is a new paradigm, techno-productive paradigm. There has been a essential transformation in how to address health and disease. Informatics have automatized, robotics also has interfered in productive activity, the development of new materials and nanotechnology, with fundamental applications in health, biotechnology and genetic engineering change the manner in which health is provided. And as a paradox, this technological development doesn't produce well-being because we have profit. And which is the impact of that change in the area of health? In this area, we have health and medicine in the circuits of production and accumulation of capital. At present, health is part of the economy. Health is a fundamental, profitable space, and this makes that a fundamental player is the medical, industrial, financial complex. And we can see here the third and the fourth industries in terms of profit are the pharmaceutical industries and the medical equipment industries. What is that medical, industrial, financial complex of health? Is the set of great corporation, private corporation producing medicines, vaccines, technologies, or they sell insurance or services, which are interested in their own profit more than in the health of people in general. And they want to continue like that. And this has changed medicine. We had a clinic, a medical clinic based on low complexity technologies. When Juan was in Africa, he took in his bag all the technology. At present, we have a hyper technological medicine which is very, very fragmented. In old times, we needed 1, 2 doctors. Now we need 10, 15. There is not a physician that can see me integrally because of this absolute fragmentation in health, imaging, robotics, biotechnology, and these are equipment, machines, very costly machines that transform public health to which is used in the capital market. That means to say, market has invaded all the spaces in life. And to understand the topic of health implies understanding that it is only a technical area, and it's also a political space of power, a legitimation of power. but it's a space of economical interests, where you have the medical, industrial, financial, medical complex, because health is one of the economic sectors more important. New diseases are invented. So there are new hyperactivity in Lima. There are schools where more than 50% of the children are medicated with a diagnosis of disease that may exist because it was created a very big business for the government. And I want to mention this phrase, which I think is very important. Henry Garden was the director of Merck, and 30 years ago he said, and he wrote, "My dream is to produce and sell medicines for the healthy people." He was not happy enough with the medicines sold to the sick people. So with that concept, the pharmaceutical has expanded its market, creating new diseases, changing the limits and criteria of diagnosis, convincing medicines to prescribe medicines and the people to use those medicines. In that book on how new pathologies are published, and this is Richard Roberts, which is a Nobel Prize of Medicine in 1960s. The pharmaceutical companies are not interested in curing diseases. They are interested in making them chronicle. So from that derives the benefit of these companies. So this Marcia Angel, publisher of New England Journal from 77 to the pharmaceutical industry, has left aside his initial purpose to discover and produce useful medicine. Now it's a commercial machine for selling drugs of dubious benefits, and uses the richness and power to cover all the institutions that appear in its way. So if we have this evidence, this is her book, The Truth About the Pharmaceutical Industry. And this demonstrates this is the profit rate of the pharmaceutical industry, and down below of the rest of the industry. So my final words, which is the fundamental contradiction? The fundamental contradiction is between a vision of health as a human and social right that has to be guaranteed by the state with public policies that defend the right to health, and a view of health as a merchandise subject to the demand and supply, where the policies favor privatization. And my question that I make is, it is very difficult to build policies to guarantee the right to health when profit is one of the fundamental engines in those policies. In the globalized world, who decides in health? Who formulates the policies? In some countries, the medical industrial complex is important. Countries in which health systems are built. In some other countries, like in Brazil or Venezuela, where the Constitution said that health is a right, so the industrial Mexican goes little by little making public policies. He's not using the mic, that is why it's difficult to listen. But he said that there are countries in which the medical industrial goes little by little in the interstices, trying to have its place. So we have, it is based on the selling of private insurance and invigorating clinics. And in the rest of the world, there is a great confusion, and the medical industrial complex uses the incoherences and contradictions for the fundamental trend in health policies, which is to take funds from the state, devising policies so that state may use those public funds. There is another thing. What can we do? We have to build public policies to defend the public. We have to build, strengthen public health systems and universal ones. We have to make research and qualification to produce knowledge and professional for the public, not for the market. We have to strengthen a vision of the social determinants of health to generate policies and health systems which are public and universal. And this has to be a part of the democratization processes and transformation processes of society. In other words, to propitiate a change of paradigm and to a familiar community, intercultural health, which is a part of the policy of action on determinant social health, mainly for welfare. This is the end. To build public policies to fight inequalities and act on social determinants is an ethical rule. Social injustice and concentration of region is killing a lot of people. Thank you very much.